Hello and good afternoon. My name is Zulima Chavez, and I am the Support Center Manager for the Asthma and Allergy Foundation of America, or AFA. This episode is produced independently by AFA and made possible in part by support from Amgen and Genentech. May is Asthma and Allergy Awareness Month. This year's theme is Make Asthma and Allergy Treatments Accessible for All. People with asthma and allergies need access to affordable health insurance, health services, and medications. AFA works diligently to support public policies that will benefit people with asthma and allergies. Today, we're talking about health policies that affect asthma and allergy care with Naomi Seiler. Naomi is a professor at the Department of Health Policy and Management for the Milken Institute School of Public Health at the George Washington University. Naomi, welcome and thank you for joining us on today's episode.
Thank you for having me.
Nearly half of children with asthma rely on Medicaid or Children's Health Insurance Program, also known as CHIP, for coverage. How do Medicaid and CHIP currently serve people and promote access to life-saving treatments like inhalers and epinephrine?
So just to give a little basic background about the programs, Medicaid is a national program. It's funded in a shared way by the federal and state government, and it exists in every state. Many people in the Medicaid program are in managed care plans, and sometimes those plans have different names in a state. So it might have sort of a nickname related to the state's name. Sometimes people don't even realize, oh, that plan I'm in, that's Medicaid. But what Medicaid does is it serves people at low income levels around the country. Before the Affordable Care Act, Medicaid mostly covered people in what were known as traditional categories of coverage. So children, pregnant women, people with disabilities, people over 65. The Affordable Care Act gave states what turned out to be the option to expand Medicaid to all low-income people under about 138% of the federal poverty level. So that made this program available to a much broader set of adults and also wound up bringing in a lot more kids, even though kids were eligible earlier. Just sort of expanding a program tends to bring in more awareness of the program, and that can get, more kids enrolled as well. CHIP, the Children's Health Insurance Program, is a related program, looks a lot like Medicaid in some states. Sometimes it has some differences, and that covers children whose families earn a little too much to be eligible for Medicaid, but was created to make sure that we didn't have such high rates of uninsurance among children who are still at what are fairly low income levels. Medicaid is a really comprehensive program. It covers doctor's visits, emergency department visits, urgent care, drugs. Pharmacy is technically a optional benefit for states, but every state has chosen to cover them. And as you noted, Zulima, about half and more, depending on the state, of kids living with asthma are reliant on Medicaid or CHIP as their form of health insurance. So it's extremely important for them.
Yeah, thank you for explaining that and raising that point that it is a very important program. Recent budget actions threaten cuts to the Medicaid program. Can you talk more about how likely it is Medicaid will see funding cuts and what those cuts could mean to people who rely on Medicaid for healthcare?
Yeah. So unfortunately, what's going on right now in Congress, it's a process people may have heard about in the news, and it's very wonky, called reconciliation. What it comes down to is that Congress is trying to find money to pay for tax cuts that it would like to extend at some higher income levels for people. And to do that, they are looking at a bunch of programs, including Medicaid, to make cuts. We don't know how these cuts are going to turn out. There's been some great, enormous pushback from people across the country, including many folks who are friends and members of AFA and kids with food allergies, pushing back, saying, no, please don't cut Medicaid. It's really important to my family. It's really important to my community. It's really important to health systems overall. There are a lot of rural areas where without Medicaid, the hospitals would close because that's really the main sort of funding stream, keeping some of these health structures in place. There are a bunch of different ways that folks have proposed cutting Medicaid to make some of these cuts and potentially pay for these tax, cuts over on the other side of things. So some examples, people talk about work requirements in Medicaid. So saying, well, people should have to work if they're getting Medicaid. Well, most people with Medicaid are working. And when they're forced to sort of report it officially, sometimes the systems make that extremely hard. And so people, whether or not they're already working, wind up losing their coverage for administrative reasons. There are proposals to cap how much money a state can get total for Medicaid. Right now, if someone's eligible for Medicaid, they're entitled to get it. And so if a state has a lot of low-income people who are eligible, the state can get that money. If you capped it and said a state can only get up to this much money, then people who are eligible beyond that are out of luck, or the state has to find ways to cut benefits, make it harder to be eligible in order to stick with that budget. There's lots of other different ways that it's been proposed to, quote, reform the Medicaid program. But what it comes down to is, if you're going to cut billions of dollars from the Medicaid program, people are going to lose coverage, people are going to lose benefits, and it's going to have a really huge impact, not just for people with asthma or allergies, but for everyone who's reliant on Medicaid for their health care.
Yeah, and that brings me to my next question. So, how will these Medicaid cuts impact the broader healthcare system? What are those other impacts that we can expect?
Yeah. So again, we still don't know precisely what cuts are going to happen, but we can certainly see, we can make guesses about what different impacts might occur, right? So first of all, again, cutting, one of the sort of numbers out there is that $880 billion have to be cut from the Medicaid program in order to reach the kinds of cuts that that the majority in Congress is looking for right now. You can't make cuts of that magnitude without taking huge slices out of what the federal government is contributing to the Medicaid program, right? So there are some organizations out there that are doing estimates. The Center for Budget and Policy Priorities, the Kaiser Family Foundation, folks can look if they're interested at, well, what would this mean? How much money would this slash? And, generally speaking, it's not money that states could really make up on their own. And that's more and more true. States that have a lot of folks who are dependent on Medicaid and who are lower income are also states that don't have huge budgets where they could just say, oh, that's fine, we have state funds, we can cover this gap. So, whatever the cuts are, first of all, you're likely to see a lot of loss of eligibility. As I noted, particularly in rural areas, there's a lot of concern about, there have already been many, many hospitals closing in rural areas over the last decade or so. They have been closing disproportionately in states that have not expanded Medicaid. And that's in part because Medicaid is a big contributor to making health systems, hospitals, and related systems sustainable. You also see, when people lose eligibility for Medicaid, first of all, you see worse health outcomes. People who have asthma, allergies, or any other health condition are less able to access services and access their medications. People don't get preventive services because, particularly if you don't have health coverage and you're already living at a low income level, it's very hard to decide, oh, I'm going to go pay out of pocket for some of this preventive care. People will turn to other kinds of safety nets in the community. So, for example, federally qualified health centers that serve people on a sliding scale. But, those centers don't have infinite resources, infinite staff. So there's a question of how much of the burden they can take. People may turn more to manufacturer assistance programs, for example, for medication. And that's important too, but it's not a promise. There's nothing in stone about manufacturers having to extend that generosity to people forever or to pick up all the slack, right, if Medicaid gets a lot smaller.
Yeah, wow, that is, in the news, we hear a lot about budget cuts, funding cuts, and we don't always understand what the implications are, what that'll look like in the day to day. So I really appreciate you explaining that. It really helps people to be aware, how could this impact me, impact my family, and my community?
Yeah, and I will say, as of today, we're speaking on April 22nd, right? This is still, the process is still happening, and Congress really is hearing the message from people contacting their senator or their member of Congress in the House of Representatives saying why Medicaid's important to them and why they don't want significant cuts to happen. That message is getting through. It's getting through to some members of both parties, and so this isn't a done deal. And I think if people feel strongly about this, they should certainly exercise their right, to reach out to their member of Congress and stand up for Medicaid.
Yes, definitely. Prior authorization, step therapy, and formulary restrictions often delay or deny access to critical asthma and allergy medications, including biologic treatments. Can you talk more about these practices, what they are, and how they affect patients?
There tends to be tension between pharmacy manufacturers and health insurance companies and systems about drug pricing. Many drugs, as you all know, are extremely expensive. Insurance companies would prefer to keep their costs down. So one way that that insurance companies try to keep costs down for pharmacy spending is to put different limitations on their enrollees' access to drugs. And you mentioned some of these. They all fall into sort of a bucket of something called utilization management. One is prior authorization, which is saying generally your prescriber needs to get permission from the insurance company before we will cover this for you. And that in itself, can be a barrier, can be a delay for people to get something. There might be specific requirements in the prior authorization terms that are not necessarily clinically relevant, right? A drug might be approved by the FDA for a bunch of reasons, but an issuer might say, well, we're going to do prior authorization and only approve it for certain reasons. Another category is step therapy, which is basically saying an enrollee would have to try certain drugs, typically cheaper drugs, although not always, first, and not succeed with those drugs essentially in order to be allowed to get coverage for typically a more expensive drug. And of course, if you think of the example of someone with like moderate to severe asthma, saying, well, you have to try other drugs. Your provider might not think if your provider thought those drugs were what's best for you, they probably would have prescribed them first, right? And they didn't. So, but you need to try them anyway and go through more time with your asthma uncontrolled until we will agree, okay, fine, yes, we're going to pay for the drug that your doctor actually wanted in the first place. So this is really, it's a challenging area of policy because they're very, very commonly used, these kinds of limitations on drugs. And there is definitely a tension, not just in the allergy and asthma space, but across a lot of disease advocacy areas towards how can we, what's the answer here? Sometimes states will say, pass a law that says you can't require prior authorization for this kind of drug, right? Or you cannot use step therapy for this category of drug. But for the most part, we still see these kinds of limitations for most drugs in most states. And it's a real challenge. This is something I will say where the doctors, the prescribers, particularly the American Medical Association, they don't like prior authorization either. They think, I'm the provider, I know my patient, I'm the clinician, I should be able to help them determine what's best for them. And instead, not only are you not taking my word for it, but you are making my office spend tens of hours, per prior authorization to get approval instead of providing medical care, right? So there's some real sort of ongoing allyship and coalition building around trying to address these kinds of barriers to care.
Yeah, and I'll share, we get a lot of stories of people who run into challenges with the prior authorization, with the step therapy, and it can be incredibly frustrating when you really need access to your medicines and it's taking a lot longer than you would have hoped. And then there's also the high cost of medicines. It's a common concern that we hear in our community, and one of the main reasons why people may not take their medications.
Absolutely. I mean, cost is a huge issue. And, there's certainly factors that go into that manufacturers can talk about as far as the research that goes into developing a drug, the advertising. At the same time, first of all, these drugs get purchased at much lower prices in some other countries. And, setting prices that simply aren't sustainable for our healthcare system isn't working, right? The current system, as you noted, is not working for a lot of people who really consistently face challenges affording their drugs or just accessing them without weeks or months of stress.
Yeah, and what are some of the complex factors that influence the cost of medicine in the United States?
Yeah, there's so many. I mean, one, again, is that for the most part, manufacturers can sort of set the price they want. It's an interesting area for policy right now because as of quite recently, starting last year, basically, the Medicare program for the first time is allowed to negotiate certain drug prices with manufacturers. Until now, Medicare couldn't negotiate. They just had to pay what was asked. So it is interesting. There's some asthma drugs coming up on the negotiation list. And it will be very interesting to see sort of how much the negotiations lower the prices and what those changes mean for enrollees, how much of those savings go to people living with asthma who are using Medicare as their health insurance. There are a lot of other factors. We have a system in which pharmacy benefit managers, or PBMs, which a lot of people may have heard of, essentially they're the system acting as the middlemen between pharmaceutical companies and issuers. So they negotiate with the pharmaceutical companies. They create formularies for insurance companies that say, okay, these are the drugs we cover. These are going to have prior authorization. These will have step therapy. There are a few challenges that a lot of policymakers and advocates are looking at with PBMs. One is that there's not a lot of transparency around pricing, around their motivations. They are clearly, as middlemen do, they are getting profits off of sort of serving this role in the middle, and that just sort of drives costs further. They also have incentives that aren't necessarily aligned with the incentives of consumers and patients. So, for example, a pharmacy benefit manager, a PBM company may get more profit by coming to an agreement with a certain drug manufacturer and getting certain rebates back and a percent of those rebates for a drug that ultimately will cost an enrollee more because, say, it's a brand name drug and not a generic and it's more expensive. So the financial interests of the PBMs are often not aligned with people who are enrolled in health insurance programs. So that's a big factor as well.
Yeah, people may have heard about PBMs, the pharmacy benefit managers, in the news, but may not necessarily know what they are or what their role is in affecting drug access. How do PBM practices, rebate structures, and pricing reforms impact the affordability for asthma and allergy treatments?
I'll give an example. One of the ways that PBMs work sort of in their negotiations with pharmaceutical manufacturers is that PBMs will say, if you offer this price, for example, or if you can offer this kind of rebate, to this purchaser that I'm negotiating for, we will make your drug a preferred drug on the formulary. So it's sort of, they can use formulary placement. Is this a tier 1 drug with really low cost sharing, or maybe tier 3 with higher cost sharing, et cetera? They can use that placement as a bargaining chip in their discussions with manufacturers. So they might wind up getting a really good rebate from a manufacturer, which means really good profit for the PBM by putting that manufacturer's drug on a preferred tier. So people are more likely to use that drug than its competitors. However, that drug might be more expensive than the competitors. And so ultimately, it's costing the system more because of the incentives that can be in place for PBMs. There are a lot of the states and federal proposals to look at PBMs are about at least starting with transparency, right? So sort of disclosure of what kinds of negotiations are happening and where the benefits are going, or requiring that the savings that are accrued based on certain negotiations go to patients, not just to the PBM and not just to the insurance company, but to the patients themselves who might have to purchase these more expensive drugs.
Last year, price caps were announced on many asthma inhalers, and some states have even put price caps on epinephrine. And while this is not a perfect solution, AFA has supported these efforts to reduce the out of pocket cost of these medicines. What are some other policy solutions that could help to improve access to medications and treatments?
Yeah. So these kinds of price caps, I 100% understand AFA supporting them because, as I said, you can go on for years about how it's so complicated and there's all these factors and incentives for the manufacturers and for the insurance companies. But meanwhile, the consumer is there with a huge amount of cost sharing and huge barriers, right? And so if you can kind of slice through everything else and say, you know what, we know that pharma and the issuers are going to keep battling this out. In the meantime, we don't think people should have to pay more than, say, $15 a month for insulin, right? Or more than $25 for an EpiPen. Then you are at least, for now, setting a ceiling for how much people can be expected to have to pay for these really, really important drugs. I think these caps also they sort of focus policy attention on drug pricing in a way that is useful, because it really gives like this sort of EpiPens and inhalers and insulin seem to somehow work really well as a bipartisan concrete example for lawmakers of, well, of course people should have access to these, and of course they should be affordable, right? So those kinds of price caps are definitely important. As far as other kinds of approaches to address drug pricing in the meantime, it is going to continue to it's like squeezing a balloon, right? You squeeze it over here, and so prices come up over here. You squeeze it there, and, premiums get raised here. So it's going to take a lot of very deliberate and thoughtful policy attention, which we may or may not see at the federal level in the short term. But first of all, the Medicare negotiations will maybe have some impact on costs, sort of across sectors, not just in the Medicare program. I think, access to generics, which, we know is something AFA has also always supported, right? Generics, just to level set, are an equivalent to a drug that is made by not the original manufacturer who had a patent on it, but by other companies after that original patent has expired and after the manufacturer has lost their sort of exclusive right to sell the drug on the market. So generics are safe, they're effective, and they're often much more affordable than a brand name drug. And so increasing access to generics in formularies, making sure people understand, generics are safe, they're effective, and they really, those are just increasing uptake of generics is a really important way to sort of save the system money overall. This gets slightly more complicated, but not very, in the world of biologics. Biologics are kind of a blanket term for a group of drugs that are, many of which are relevant to asthma and allergy. They're made through sort of biologic processes. And so biologic drugs don't have generics. They have what's called biosimilars, because they're not identical, but they are found by the FDA through scientific evidence to have the same kind of uptake and the same effectiveness as the original biologic drug. And so similarly in that area, once biosimilars are available for asthma and allergy drugs, there should be a lot of education and attention towards making sure that people who can appropriately be switched to those more affordable drugs are doing so. It'll save them money. It'll save the system money.
Yeah, I'm glad that you mentioned like the safety of the generics. That's a concern I've also heard where people say, I don't think this works the same, it's different. And so it's helpful to just reaffirm that they are
Yeah.
an equivalent to those existing medications.
Yes, they are. And of course, if someone's provider thinks that there's some particular reason that a generic might not be appropriate for them, maybe it has a different coating on it, right, than the original pill, that should be something that their provider is able to request
Right.
an exemption for, whatever. Similarly, for biosimilars, they are similar, they're not identical. And if there is a clinical reason for a specific individual that a provider thinks someone needs the branded drug, there should be an allowance for that in some way. But people do need in general to understand that these drugs should work the same way and are much more affordable.
Mm. Yeah. And for our listeners looking for patient assistance programs, assistance with copays, and just those medicine costs, we have developed a resource on our drug assistance programs webpage. We're going to include the link in the description below. Check it out. It includes a list of different programs that we've compiled together, and you can review that list, see if there's any programs you might be eligible for, reach out to them, and get more information to get assistance with those costs that you are experiencing, those out-of-pocket costs.
Great. And yeah, as you know, Zalima, these manufacturers typically have two general kinds of programs. They have copay or cost sharing assistance programs so that people who have, typically it's only for people who have private insurance, but if you have insurance through a marketplace or through work, but you say, I have $300 copay per month, et cetera, those copay or cost sharing assistance programs can help. And manufacturers also often have programs for people who either don't have insurance or have insurance that doesn't cover their drug at all, right? So whichever of those buckets you fall into, you should definitely check out those resources.
Yes, definitely. Before we end today's episode, I want our listeners to know that AFA is also listening, and we advocate based on the needs of our community. We need to hear your stories of challenges that you're experiencing and getting healthcare or treatments, and you can write us at afa.org/advocacy team. As I mentioned earlier, the month of May is Asthma and Allergy Awareness Month, and our efforts this year will be focused on elevating the voices of the community and advocating for better access to care. To get involved, we encourage you to follow AFA National on social networks, sign up for our newsletter, join our online community, and follow our action alerts for Awareness Month. We will provide those links in the description below. And for more information, you can visit afa.org/awareness. Naomi, thank you so much for joining us today to discuss health policy and its impact on affordable care and access.
Thank you so much for having me.
We hope our listeners of the AFA Noon Chats podcast found this informative and actionable. Don't miss our future episodes. Remember to like and subscribe to our podcast, which is available on Spotify and YouTube. The information presented on our podcast is educational and not intended to provide individual medical advice. Please talk with your healthcare provider for advice about your personal health. If you have questions or want to talk to someone about asthma or allergies, our Asthma and Allergy Foundation of America online community is always open. You can find it at aafa.org/join. Before we say goodbye, we'd like to thank Amgen and Genentech again for their kind support of this episode. Have a good afternoon, everyone.